pleasure to be here today. We have we are very lucky to have a galaxy of so many vitreoretinal surgeons from almost all corners of the world. I welcome Slavomir from Poland. He's the chairman of the session, and Tural from Azerbaijan. He's the co-chairman of the session. I'll be moderating the session, and I think we can make a start by inviting Gampolo Gini from to give the talk on dealing with macular folds. I apologize if my pronunciation with the names is not correct. I apologize in advance.
Well, you got mine correct. It's Jeannie, yes. So that's perfect. Thank you. Hello, everyone, and thank you again for being here. Thank you to the organizers for this exceptionally beautiful meeting and for this very warm welcome in a wonderful country, which I admit I had not visited before, and I will be back if wanted. So we can start with macular folds. Can we have the first slide, please? So what is the definition of macular folds? Well, a macular fold is essentially a rare complication of rhegmatogenous retinal detachment surgery, and it can occur with any sort of repair surgery, so be it a buccal, a vitrectomy, or even traumatic retinopexy. The reason why this happens, or we'll see in a second, but the significance is essentially due to the location of the macular fold itself. So if you have a fold which is obviously in the periphery, the laser pointer. If you have a fold which is in the periphery, obviously that is not of concern, and you can actually wait and see how things go. If you have a more centrally localized fold where you have face-to-face photoreceptors, obviously you need to intervene rather quickly before the situation becomes definitive, and obviously the damage is irreversible. So what is the mechanism of fold formation? This is an attempt of me drawing, not very good, but essentially the fold formation results from compression and trapping of stretched, redundant neurosensory retina, which can be compressed during the surgery itself. So think of, if this is the detachment, this is a gas bubble going in. Actually, you can see that this is pushed to the side. This redundant retina is pushed to the side and forms this fold. But even better than my drawing, which is very amateur, there's actually a video which I've taken from this very good article, which I invite you to read, and you can see the dynamics of how the fold itself forms. So you have the fluid which is pushed to the periphery, and then the laser is actually applied here, and so the laser is applied here, but you can see that then as the tamponade is placed back into the eye, you will have that the fold forms, because we have, I don't know why it's not working, but here it goes. And you can see how this fold simply forms because of the fluid which is underneath the retina being pushed towards the center of the retina itself. So what are the risk factors for fold formation? Well, there are several. One is, for example, a bullous retinal detachment, the recent onset of the detachment because the fluid underneath the retina is still not very thick. The retinal detachment running through the macula itself, and finally, if you have a high circumferential scleral buckle with or without gas. How do you prevent this? Well, the prevention obviously passes through a complete and appropriate vitrectomy or other procedure which is aimed at draining completely the subretinal fluid, and then appropriate positioning. I think this is quite important. Now, generally, what we tend to do is to position the patient face down, and by doing that, we hope to push the fluid which may be trapped in the posterior pole to the periphery of the retina. Now, that is one option, but a more efficient option is probably the steamroller technique, which I think you all know. Essentially, with that, we position the patient on the temporal side of the eye affected, and by doing that, we hope to get the fluid pushed towards the periphery of the temporal side, and with a steamroller technique, then put the patient face down. That has been shown by many authors to be more effective than the simple face down positioning. The treatment, again, you will excuse my very primitive attempts to give you an image, but the treatment is obviously aimed at releasing the fibrin bridges which form underneath the retina, and you do that by injecting BSS underneath the retina. Obviously, it makes sense that the sooner you do this, the less these bridges will be thick and resistant to the mechanical action which aims at opening them up. So this is a case presentation. It's a superior. Fortunately, I don't have many of these, and I say fortunately. This is a superior bullous detachment which was treated with vitrectomy and gas tamponade. He was asked to actually, not the steamroller technique, but he was asked to keep the face down positioning, which he did not do by his own admission. And 1 week post-op, the fold was detected, and 10 days post-op, a review vitrectomy was performed. And this is essentially the strategy behind it. I performed an ILM peeling. I must say that I had not done, as I said, many before. Actually, this was my second case. So I did an ILM peeling, and then I asked myself, is this really necessary? But I think as we are surgeons, we always tend to peel, and therefore I thought perhaps releasing the superficial tractions could be of some use, and I did that. And then I simply injected the subretinal space with BSS, and I gently massaged the retinal fold itself and I helped myself with heavy liquid. Again, thinking that the distribution of the forces on the surface of the retina due to the heavy liquid would be more homogeneous and would therefore create less damage. The video is missing. Okay. There should be a video, but it's not here. All right, thank you.
Thank you very much, Dr. Jenny. Are there any questions, or do we take questions at the end? At the end. Okay. So now I invite Diego Martinez from Colombia to give his talk on macular hole post-retinal detachment surgery. Diego.
Excuse me, can I just show you the video? It wasn't uploaded. Here's the video.
Oh yeah, that's...
Okay, so at least you can see the video. So this is what I was saying. You can see the fold as it goes through the macula. So again, as I said, peeling, this is green, but actually it's the camera. It's dual blue. It's not obviously ICG. And then the injection of the subretinal space with BSS with a 41 gauge mechanically assisted injection. And I attempt with a Thanos scraper to gently unfold this macular fold, and then with the aid of PFCL, the procedure is repeated. I think this helps to some extent to diminish the damage on the retina, and you can see how now the fold has gone, and actually the problem is solved. Thank you.
Excellent. Over to you, Diego.
Okay, I want to thank you all for your assistance and the organizing committee for the invitation. I just want to talk about macular hole post retinal detachment surgery. Here are my financial disclosure, not relevant for the purpose of this presentation. So what do we know so far for this association? This is a very rare condition, between 0.5 and almost 2%, and it's report on all type of surgery, including scleral buckle, vitrectomy, and pneumatic retinopexy. Of all them, vitrectomy is the most common association, almost 70% of the cases. This formation of the macular hole has a variable time of presentation, between 1 month and almost 3 years before the procedure. And most of them are very tiny holes and may have an spontaneous closure without any intervention. So I want to share with you a patient I had in the clinic. This is a patient who in 2015 had a retinal detachment surgery. So he received a vitrectomy with silicone oil, and later on he had a phaco and silicone oil removal. In 2016, he refers that he had another surgery, but he didn't remember very well. Apparently, it was residual silicone oil. He came to me in 2022 with a total retinal detachment, and we see a laser 360 degrees in that moment. So we performed surgery, a vitrectomy with silicone oil, and we found 3 holes in superior temporal laser barrier, so we perform additional barrier in that side. In the post-op, he went very well. He developed an ocular hypertension that it was managed with topical drops. You see the refraction there. So 10 months later, I performed on him and removal of the silicone oil. So 1 month later to the removal, he came to me and saying me, okay, I have a central scotoma, and you can see the formation of this hole. And he said to me, okay, there are too many surgeries, I don't want another surgery, so is any medical treatment I can do? So we put on topical steroids and non-steroids, and okay, come back later. He came to me 3 months later, and you see the hole remains almost the same. So here's the surgery. You can see the laser, the anterior retina. So with blue dye, we perform a peeling of ILM, but it was very difficult. So you see many attempts to try to leave the ILM. It wasn't successful. So a second dye, it reveals a very fragile ILM. I couldn't leave a complete flap, so I decided to leave a free flap, but that was unsuccessful. So tried to remove another ILM, but this is so fragile, I couldn't find a flap like that. So like I was very desperate in that moment. So I decided to perform another dye, and you can see remnants or a membrane. I didn't know what was that, but I removed them with a finesse loop, and you can see here, and in the same time trying to close mechanically the hole. at the end, so we drain the anterior retinal detachment and leave him in gas. 1 month later, you can see this type of closure. This is a 0-8 tape closure, non-satisfactory. He refers that the scotoma was improved, but visual acuity did not. So reviewing his chart, do you remember the 2016 surgery? Well, that surgery not only includes removal of silicone oil remnants, but also an epiretinal membrane peeling. So what happened in this patient? We suppose that the formation of a hole was due to cystoid macular edema and epiretinal membrane that exerts a tangential traction. So that's why some authors say that peeling of the ILM protects to have this macular pathology, but this is not the case of this patient. So can we anticipate this? Maybe Ishibashi described this called foveal crack sign, that this is not a consistent finding. And you can see here, there's a hyperreflective line just in the fovea that later develops a full thickness macular hole. They assume that this is a kind of dehiscence of Mueller cell cones and a weakness of the foveal zone. And it's a late finding, you see, more than 200 days after the surgery. But many other series does not find this consistently. So in this patient in particular, you see that this is not the usual course. And I ask myself so many questions. If maybe the epiretinal membrane peeling induce a disruption of the Mueller cell cone and weak the foveal zone that may have a paper in the development of a macular hole, or maybe the 360 degrees induce a generalized contraction of the retina that could explain the unsatisfactory closure of the hole, or maybe that remnants of the epiretinal membrane exert enough traction to open the hole. Well, so we didn't know, but there's so many theories about that. So thank you for your attention.
Thank you, Diego. We'll take the questions towards the end of the session. Now I invite Yasmin Peralata from Dominican Republic, and she's going to tell us about the membrane-rich in growth factors for macular hole treatments.
Thanks for the presentation. Thanks to Professor Hussain for the invitation. It's an amazing symposium. I'm so pleased. I'm so happy to have new friends. I have here the solution for Diego, just to close your macular hole. Let's see and wait. Yes, yes. It has audio too. This is something that we are doing in our hospital since last 2 years, so it's just our experience in that. I'm here just the tips and what we are seeing. I don't have any commercial interest to declare. In macular hole, we can say that we have primary and refractory macular holes, but in those simple case, we just do peeling, PPV and peeling, but in those cases, there are traumatic, myopic patients or refractory macular hole. What we can do different from the techniques that we know. So we propose just to do plasmid-rich growth factor membrane. How does we prepare it? It has sound, if you can put the sound. We centrifugate the plasmid again twice. Just take the 3/3 and the charge, and the second 3/3, we try to just to rupture the plasmin and activate it. And it's the one that we use. We add calcium gluconate to 1 millimeter for each tube. Then we wait 40 minutes before use. Here's my first case. This is a patient with a very big macular hole, a myopic patient. So we made a PPV and peeling and then put the membrane. We not always use this lens, but we try to do it with this lens to the patient. We took the membrane. At the beginning, when we start to do those cases, we try to reduce the membrane. But now on, we realize that we don't have to do it. We try to do as much we can, but don't reduce anymore. In this case, that was one of the first, we put PFO just to stabilize the membrane, but we don't need to do it anymore. We've put gas and finished the case. And this other case is a beautiful case, amazing. It's a traumatic case. Macular hole is in a young patient, 19 years old. Do you see it's a big membrane? So we just attach with the border with the macular hole and let it like this. We just need to be secure in one of the border, and the other is gonna stay over there. And this one, it was a refractory macular hole. We dye just to be sure that we don't have any epiretinal membrane formation or any rest of the ILM in the first surgery, but it doesn't. We take the membrane, we go in, and put over there, just be sure that is stable. And everything is okay. Finish the surgery, and here I have this one was one of the first patients, and this is the OCT. We can see that the patient was like 1 in Lockmar, and then it goes on 2050, that is like 0.4 in Lockmar. Those are 3 cases, refractory macular hole. And other thing that we notice in those cases is the avascular zone gets more regular, and the density of the vascular in the foveal zone grow up. Here is the one of our traumatic case, young patient too, and the vision improved very well too. In conclusion, we can use the membrane. It's secure to do it. It's safe. We can obtain a good visual acuity. We can promote the regeneration of the inner layers. We can restore the retinal vascular, reducing fast and increase foveal vascular density. And for you, the message is you can use in refractory macular hole, in those holes that have poor prognosis, but the most important is in traumatic macular hole. We have amazing results in those cases. Thank you very much.
Is Khakan here? Khakan, I think one question per talk we should ask, otherwise, yeah. We have the timer, so I think talks are so interesting we may lose track of the questions at the end. So lovely presentation. It was just the consistency of this material that, the plasma, that I was curious about. When you process the plasma and then you add calcium gluconate in it, what's the logic of using calcium gluconate? What does it do? And the consistency, is it like a sort of membrane?
If you don't add calcium, it's going to be liquid all the time. The calcium is just to make the membrane, that the plasmin go like a membrane. We have to, at the beginning, we noticed if we didn't have the exact millimeters of calcium that we have to add, and the membrane get once liquid and once very sticky. So now we're just adding 1 millimeter for tube that we obtain the plasmin, and it's okay.
All right. Thanks very much. Very interesting talk. Thank you very much indeed. It's my pleasure to invite Mohammed Awal Dala from Egypt. He is going to talk about post-pars plana vitrectomy macular holes.
Good morning, Mr. Chairman, dear colleagues. I will be talking about the post-vitrectomy macular holes. I have no financial disclosures. So, as Diego demonstrated beautifully before me, the post-vitrectomy macular holes are a rare encounter. They account for 0.25% to 2% of the incidence post-vitrectomy. And we have 3 types of macular holes that occur after vitrectomy. We have the tractional one, where you can find an epiretinal membrane clinically or by OCT, which is the most common. And the suggested theory is that traction by the epiretinal membrane due to any residual vitreous cortex or PVR, sometimes a taut ILM, they act upon a weak retina with a long-standing edema and ischemia and can develop this type of macular hole. The second type of macular hole is relatively uncommon, and where you do not find an epiretinal membrane. Those are the degenerative type, and the supposed theory behind the degenerative post-vitrectomy macular hole is that chronic cystoid macular edema with all those cysts get retinal thinning, sometimes rupture of the roof of the hole with a big cyst results in a hole. This is what we call the Gentile's hydration theory. The third type is the iatrogenic type that tends to develop shortly after vitrectomy due to dissection, intractional diabetic macular edema, for example, especially with a thin roof. Sometimes the PVD induction, there are micro hole formation has been suggested, and as demonstrated earlier, especially after silicone oil remover, where you remove the ILM or remove the epiretinal membrane, you get a macular hole. There are so many risk factors for getting macular hole after vitrectomy, such as high myopia, macula of retinal detachment, recurrent retinal detachment, epiretinal membrane peeling during silicone oil removal, chronic cystoid macular edema, postoperative PVR, especially after giant retinal tear, vitrectomy, and if you have a successful vitrectomy, successful macular hole surgery followed by cataract, and you haven't done cataract surgery in the first procedure, you get Irving gas with rupture of the cyst, and you get the hole. So what all those factors have in common is ischemia, edema, and degeneration acting upon a thin, weak retina. Those are the risk factors. What are the prognosis? Or what is the prognosis? The anatomical prognosis is relatively good. There is closure after surgery in around 75% of cases. However, visual improvement is not that good, and this is because any previous macula of retinal detachment, especially for a long period of time, you have a thin retina and the atrophy of photoreceptors, myopic macular degeneration, and diabetic macular edema with edema and ischemia. So I will present three cases of each of those type. The first case is the tractional type retinal detachment. This is one of my patients. I did pars plana vitrectomy with silicone oil for giant retinal tear and presented 2 months post-operative with inferior PVR and membranes detaching the macula. Pre-operatively, I couldn't tell there is a macular hole, but during surgery, as we can see here, I started by removing these membranes of the PVR, and as I removed the membrane, I discovered a hole intraoperative. So not necessarily you can diagnose the hole pre-operatively. I started by draining the fluid from the hole and staining the ILM with brilliant blue and trying to remove the whole membranes and ILM with the attached membranes on top. This is a post-giant retinal tear, and the hole closes in a nice U-shaped closure, but with minimal improvement of vision as expected. The second type is where you do not find an epiretinal membrane, is the degenerative type. There is no epiretinal membrane by OCT. It's a 30-year-old, highly myopic female. She had done pars plana vitrectomy and silicone oil for rhegmatogenous retinal detachment and PVR, followed by silicone oil removal, as again silicone oil removal, and trying to peel any ILM or epiretinal membrane is a risk factor. Then 3 months follow-up revealed this almost giant retinal hole. It's a 1.4 millimeter, as we can see here, and it is closed in a flat open position. So I had to take the patient again to the OR and doing ILM peeling, trying to deal with such large hole. I didn't do inverted flap at that time, hopefully to release the ILM. I mean, there is no traction, there is no epiretinal membrane. So it's just a degenerative type. It could be a cyst. The hole was getting smaller with relative improvement of the scotoma, of course, of no improvement of vision. The third type is the iatrogenic type, and this type tends to present early after surgery. And this is a case of a diabetic case with diminution of vision in the right eye and right advanced PDR. This is the scan pre-operative, and as we can see here, is tractional diabetic macular edema with a very thin roof of the macula. This is a cyst, very thin roof, and after surgery, we get this micro hole or very small hole as expected because of de-roofing during surgery. Those holes tend to close spontaneously. We waited for 6 weeks, and as you can see here, the hole closes without any further intervention. So the take-home message: secondary post-vitrectomy macular holes are a rare encounter, and the tractional type, where you find the epiretinal membrane, is the most common, especially after silicone oil removal. Sometimes you get the degenerative type without ERM, which might present in a flat open configuration. Those macular holes might benefit from inverted ILM flap techniques or autologous tissue. And the iatrogenic small or micro holes after surgery have a high incidence to close spontaneously. Thank you very much.
Thank you very much, Mohammed. Now I would like to invite Hussain Ahmed Khakan for his talk, Failed Macular Holes and What's Next.
Good morning, ladies and gentlemen. I will talk about the failed macular hole surgery. It's very easy to do primary macular hole surgery. You know many techniques, and success rate is 90, 95. Some techniques has 100. So the issue is not doing the primary macular hole surgery. The issue is when it fails, how much options you have and how much successful options you have. So I will try to elaborate and describe few options that are more practical and easy for the patients. I have no financial disclosure for this talk. So this is a preoperative fundus image. This patient underwent the vitrectomy and macular hole surgery. You can see the macular hole about the size of optic disc here. You can see. So what options you have? I mean, you can get something like grafting of retina, how much successful results we have. We all know in last 12 years, and other options. So you can see the minimum size is 1,000, maximum is 1,400. So what to do? Everybody has its own way of doing it. So the patient already underwent surgery for macular hole, so I have to do cataract surgery and implanted the intraocular foldable lens in this patient. So I just try to stain it because the surgery was not done by me, so I try to stain it whether the ILM is there or not there. So I injected the brilliant blue, and I'm just showing you the surgeon did the great job. He didn't do anything wrong the first one. He did peel the ILM. I am just showing you the arcade to arcade that there is no stain. It's not very much clear. Can you switch off the lights, please? So here you can see he did a large ILM peel in this hole, but it didn't close. So what next? So my plan was to do a amniotic membrane graft. So I prefer to do amniotic membrane graft in these cases, and I prefer to do it under the air. So we have published this technique in Retina in 2022, and it is the largest series in the world that have published in this technique. This is amniotic membrane graft, and my technique is I will just drop it near the macular hole, no PFCL, nothing, it's just under the air. So then with a soft tip extrusion needle, I will drag it over the macular hole. Our technique is not to tuck, not to plug it. When you plug the macular hole, you are just doing a failed macular hole surgery. You are not letting the neural tissue to centripetal movement to concise. Plugging and closure is nothing. Yes. So we give a just scaffold of amniotic membrane over the hole. This concept is now more popular in primary macular hole surgery. When people talk about the temporal flap, just giving a scaffold over the macular hole. So here I just gave the scaffold and just left it. So here you can see the post-operative. This is type 2 closure, but it is very precise. Why in our publication we mentioned that when you get a early second surgery for failed macular hole with the same technique, then you get 80% of type 1 closure. Earliest it is within the 1 month. So if you get delayed and then use the amniotic membrane graft, then the more incidence is about the type 2 closure. So if you have a failed macular hole surgery and you want to do amniotic membrane grafting, do it as quickly as possible and you will get about 80% of success in the closure of the hole is 100% in this technique. But type 1 is more than 80% if you go with the, within the 30 days of the primary surgery. So this is, these are our post-op follow-ups, and we followed this patient for lifelong. We have 33 patient series in this, and this is the largest series available in the world for amniotic membrane graft till the day. So this is another case where I will try to show you another technique of how to deal with the failed macular hole surgeries. So I just injected the triamcinolone to see the whether it is there or not. Staining the ILM, I do if there are any ILM left by the previous surgeon. So you see the previous surgeon tried to did the temporal flap over there. So we peeled the ILM. The first surgery was done as a temporal flap. So we peeled the ILM, and then our technique is to the hydrodissect of the macular hole. Because our concept is when you get the failed macular hole surgery, your margins and tips of the macular hole are stick with it. So with the soft tip extrusion, first I did the hydrodissection and then massage of the macular hole. What is the hydrodissection? You just go and push the fluid inside the macular hole and get relieved it from the traction. So this is our second technique, and we have already published this one. This was named as hydro and massage, so it is much useful if you don't have amniotic membrane graft or any other option in your patients. So these are few techniques, and the other techniques, just play it. So other techniques you can find in the world, but I don't feel that those are much more promising regarding the visual acuity and closure of the macular hole. This is another case. I think it's the repeating the same one. That one is not playing. So okay, anyhow. So this was the macular hole size in this patient, about 900 micron meter. And this is the preoperative, and this is the postoperative OCT of this patient with the macular hydrodissection and macular hole massage. So thank you so much for your kind attention. These were the few presentations, the few techniques that I wanted to describe. This is amniotic membrane graft with a hydrodissection and without hydrodissection. If we will have any question, if I want to take, if any question at right now, if any.
Excellent talk, Hakan. I think because of shortage of time, we move on. Our next speaker is Wael Ahmed Awais, our international speaker from Egypt. Is he around? Oh, he's giving his presentation. Okay. So he's going to talk about giant macular holes in complex trauma. So we will know, it will be like a continuation of Hakan's talk on management of large macular holes or failed macular holes. So we'll get, okay, sure. We'll get to know more about how to deal with large macular holes.
Well, this is good morning, everybody. This is a case report presentation for a single case of a very large macular hole in the context of trauma. The case is, help, please. Yeah. The case is a young female who was exposed to a trauma by a needle. She had a vitrectomy performed and cataract surgery without IOL implantation and silicone oil. But she's presenting, or she presented to me with a full thickness macular hole, more than 1,700 microns. That's why I consider it philosophically as a giant macular hole, a retinal fold nasal to the optic disc with a recurrent retinal detachment localized at this area. It is a silicone filled oil and a phakic. So the problem here is that if I just remove the silicone oil, I expect the retinal detachment to extend and to have a frank recurrent detachment, and the the large macular hole is still there. So the question was how to end up the surgery, how to close a macular hole that is too large like this without risking a recurrent retinal detachment that would destroy all the steps that have been done. I started the surgery. I had, by all means, to remove the silicone oil at first and to examine, after the removal of the silicone oil intraoperatively, what will happen to the retina. But fortunately, the area of the detachment was still localized to the nasal part. I tried to detect fibrous tissue, PVR tissue, frank PVR tissue that I can peel, thinking that maybe I would just reattach the retina simply, but you can see that there is a circumferential peripheral anterior contraction of the retina, and I thought about a localized inferior retinectomy. Maybe it may help in the situation. And then with perfluorocarbon liquid, I tried to reattach and to reevaluate. Each step I'm doing in this surgery, I'm performing the step to reevaluate further steps. How can I do it? Of course, we all know and we are trained that there is no localized retinectomy. We do it either 180 retinectomy or 360, but I had to do it in an untraditional way based on the situation. After that came the main problem. I think a large macular hole like this, which looks like it is an iatrogenic hole related to the vitrectomy that was done, or a traction later on. My only option, as I think, was to do an autologous retinal transplantation. But I had a problem in the case. No part of the retina is healthy enough to retrieve a graft in this case. The area that was close to the retinal fold, to me in this situation, seemed to be the relatively healthiest of all, because all the other parts of the retina were unhealthy. There was scattered laser performed in the other parts that were attached in the retina. And so I had to choose between the least of the bad choices that I have. But anyway, I had the target. I want to close the macular hole, whatever the price. I am now inside the vitreous cavity, and I have to find a solution. I placed the autologous graft in place, and by the end, I inject silicone oil under air. I performed a PFC air exchange in the beginning, and of course laser at the area of the graft and the area of the retinectomies, and 360 laser prophylactic, as I usually do in trauma cases, and silicone oil tamponade at the end of the case. This is the OCT that was performed 3 months after the surgery. Well, the graft is filling the hole, a little bit bumpy, because I cannot measure it accurately to have the graft that is equivalent to the diameter of the macular hole and makes it flat. So I thought to have it a little bit bumpy, better than to have adhesions or an incomplete closure of the macular hole. But Of course, as expected, the vision did not improve. But I think this was the best solution I can do in a situation like this. If you have another suggestion, you would suggest to me what would have been the better solution. But I wanted to present an unusual case that I experienced once in my life. Thank you so much for your attention.
Thank you for a fascinating case. I have a question.
Yes.
When you choose to select a patch graft, what do you think is a patch graft?
Ah, yeah.
Do you think is the ideal place for it?
Well, the first choice is usually an ILM flap. If
No,
I have to
if
choose
you're taking
between,
a retinal patch graft or an autograft,
if I
as you
have
did
to,
in this case,
if I do an autologous retinal graft, I usually don't do it as a primary choice. My primary choice in a macular hole up to 1,000 micron diameter.
this was a
is-
1700 microns hole.
This is 1,700.
Yeah,
huge.
1700.
And I expect that it is an iatrogenic. And it is a trauma case, vitrectomized before. So I was, of course, an ILM flap wouldn't do the thing in this because it is very large. I need to fill it with retinal tissue. A very huge, a large macular hole, very large, more than 1,000
I have
micron.
personal
wouldn't-
experience with these as well. That's why I was asking, what do you think is an ideal place for the selection of the?
The selection is upper temporal, after the upper temporal arcade.
Closer to the arcade, as
Closer
close to
to
the
the
arcade
arcade.
as possible, I
Yes.
think. And
Yes.
the selection of the size is also very important. It should be
The
slightly bigger than the 1700. So,
Yes.
because it tends to shrink, and I've even seen it slipping behind the retina through the hole. So the size should be bigger than the size of the macular hole itself.
Okay.
Thank you very much.
You're
Thank
welcome.
you.
Thank you.
Our next speaker is Faisal Mursa. He's going to talk about recurrent macular holes.
I dedicate my talk to my parents. Now, introduction. A full thickness macular hole is defined as a break in the fovea that causes a significant decrease in the vision. And incidence of macular hole is 4 to 8.69 eyes per 1 lakh population. The primary closure rate is greater than 90% with current methods. After closure, macular hole may reopen in 3.3 to 9.2% of the cases. In one study, Welt, PACRS, and Wong, reoperation on reopened macular hole resulted in anatomic success of 100%. It was his study. The risk factors for persistent macular hole are persistent vitreal and epiretinal traction, chronicity, inadequate gas tamponade, large aperture diameter, and high myopia. There are different surgical techniques like ILM peeling with gas, inverted flap, lens capsule transplantation, autologous retinal transplant, amniotic membrane graft, and autologous platelet concentrates. Internal limiting membrane. Kelly and Wendell reported the first series of patients to undergo successful vitreous surgery. Packard et al. Introduced ILM peeling in 1997. With this technique, 92% closure rate was found in this. ILM flap was first introduced by Mickelshaw, and it says that 98% of the macular hole closure was in his series. Lens capsule transplant was first described by Chang and Yang in 2016, and they said the closure rate was 96%. Autologous retinal transplant was introduced by Grewal and Mahmood in 2016. Subretinal blab was described by Meyer et al. amniotic membrane was first described in macular hole by Rizzo et al. First reported the use of this amniotic membrane in 2019. And relaxing retinal incisions were introduced by Charles et al. And they said the 83% success rate. And autologous platelet concentrate was introduced by Godric et al. This is a case report of 60 years old female. She was only eyed and she complained of decreased vision in the left eye. Right eye was counting finger with bullous keratopathy and ACIUL, while left eye was 3/60, arcus pseudophakia and full thickness macular hole grade 4. This is the OCT. First surgery was done and ILM peeling with gas tamponade was done and vision was improved up to 660. And you see macular hole size was decreased, but still the hole is there. Then we plan to do the second surgery. In this we do the relaxing incision at the superior and inferior margins of the macular hole. And first follow-up after 1 month, say, it was 636. Would you agree? This is the video. Play can it be? Vitrectomy was already done. We stained the ILM with the BBG to see any remnant of the ILM. And you see there was no ILM detected at the posterior pole around the macular hole. After that, we plan to do the relaxing incision at the superior and inferior margins of the macular hole. Increase the height of the bottle so that you cannot come across the bleeding, which is usual. The inferior margin, a very small cut. And then superior margin. After that, we do the air fluid exchange. After doing the air fluid exchange, we inject the autologous plasma as well at the macular hole. Clearing all the debris from the vitreous cavity. And after that, perform the air fluid exchange in this case. Approximate the margins. And then inject the autologous platelet. Next. First follow-up. Second follow-up, patient vision with minus 1.75 diopter, increase up to 618. This is the OCT post-op. Thank you very much.
Very interesting surgical video. Faisal, have you done any macular holes in which you have given relaxing incisions without the use of plasma?
So no, I use plasma as well in this case because the patient was only eyed and she was very depressed.
The reason I ask this question is that is this macular hole closure secondary to plasma or relaxing incision?
So I don't know. Because I tried.
What is the logic of giving?
I tried both the options in this case because patient was only eyed and she need vision and you see the result.
What is the logic of giving a relaxing incision? What does it do?
So relaxing incision are just like we do the Z-plasty in oculoplasty, and it approximate, and because the break was very large, if you do the relaxing incision, so it is reapproximate easily and does not cause contracture of the margins of the wound.
Okay, thank you very much.
You're welcome.
There's a question there? Can the gentleman have the mic, please? To me, it looks not right to cut the macula.
Yes, interesting technique, very nice. In one of your slides, you have that you're using in primary repair a concentration of C3F8 at 20%. Now,
20%.
Is that an error on the slide, or is that your technique, and if so, why?
No, was usually which we are using in the macular hole or all the gases. We use the usual 20%.
So, but that would give you a higher, it's not an isovolumetric.
It is a mixture of
It's an
20%.
expandable mixture if you use 20%.
I use mixture. I do not use the pure gas. I use a mixture. And in our cases, the patient behave well.
Is it 16% or 20%? C3F8.
16 to
Generally,
20% we make.
Generally use 14%, yeah. So
But we make
20 is too much.
Yes.
20 is an expansible, it's not isovolumetric, it will expand. So you will get higher intraocular pressure. I'm just wondering if that's what you want, or is it just...
We usually use 16 to 20% mixture because the exact mixture is very difficult to make in our circumstances.
Faisal, it's very easy. You have to be very specific about these things.
Yes,
SF6 is 20%, C3F8 is 16%. It's dead easy. There's no problem with making a 16% C3F8 or 20% SF6.
Okay.
So you cannot do it. It's between 16 and 20. It is 16 and the other one is 20.
Thank you, sir.
Thank you.
Thank you.
Our next speaker is our chairman anyway, Shomer. He's going to talk about persistent macular holes.
Once again, thank you, organizer, for this wonderful meeting. Frankly speaking, I came from Poland, so I've been doing ILM flaps for more than 15 years. It's a very popular technique in my country, thanks Jerzy Nawrocki. And we face not quite rare the persistent macular hole, because there is always some ILM around the hole, and you can invert the flap once again onto the free flap ILM if we have persistent macular hole. But I'm gonna just to present you two cases. Of course, we have free ILM flap, we have anterior posterior capsule, we can grab some retina from the periphery to close the hole, and we have amniotic membrane and also autologous plasma. With the retinal transplant, of course, the images looks beautiful after the surgery, but the fundamental problem is that, according to the literature, we are not able to identify IS-OS line, only external limiting membrane. So the surgery, it's quite easy. You can do it in many ways, but usually we can cut the patch from the periphery. Addressing your question, for me it's safer to cut the graft as far periphery as it's possible from the above size, just to avoid PVR after that. But I want to present two cases. This is a case of 16-year-old lady which was operated in 2016 in conventional way, so two pars-plana vitrectomy with ILM peeling with gas, the second surgery with enlargement of ILM rexis, and this is the situation after the in 2017 after these two conventional surgeries. And what next in 2000, the question was what to do next in 2017. So I decided to put anterior capsule with silicone oil tamponade, but unfortunately this anterior capsule was displaced in the periphery. So I had the silicone oil 1 month, the hole almost closed, but not completely. So I decided to go once again. And this is, you can see, this is the anterior capsule. Actually, it's so tight, it behaves like PVR membrane. And this was also the reason that it was my first and the last time when I was using the anterior capsule to close the hole. I remove silicone oil and exchange for the air, and this is how it looks like, how it looks in 1 day post-operation, 1 month, and the patient, this is 1 year after the operation, and the patient refused any other surgery for 3 years, and in 2000 and 2000 for 2 years in 2018 he suffered for 3 years. In 2021 I decided actually to remove this membrane, and this is how it looks immediately after the operation and after 1 month after the operation. This is with the improvement of vision. And the second case, it's 37 years old lady with full thickness macular hole. She was referred to me with the diagnosis full thickness macular hole after 1 surgery with conventional ILM peeling and gas, with very poor vision. But I think this was the situation like that. But I think this was the the second eye was tractional lamellar macular hole, and I think that kind of configuration was because of the removal of ILM, and actually it was iatrogenic breaks, actually iatrogenic full thickness macular hole. So what I decided to move, I've done combined surgery with Tassignon lens. I put the amnion graft, but the amnion graft very large patch to cover not only the hole itself, but to cover also all this area with cystoid macular edema, and I exchanged it PFCL exchange gas. And this is the situation. First day post-op, you can see completely closed macular hole and no cystoid macular edema. And the reason behind that is probably there are maybe 2 explanations. One is the amniotic membrane is very special membrane. It's water resistant, so it might create a barrier and to allow RPE just to pump out the retinal fluid, or maybe it works like a swamp. And actually this is the patient 2 years after the operation, and the amniotic membrane is still over the hole, with improvement of vision from hand movement to 0.2. Thank you very much.
Thank you, Mr. Chairman. We now need to move on. I now invite Mr. Dr. Ahmed Yusuf Al-Khassab from UAE for the final talk of the session. He's going to talk about macular hole, different etiologies, size, and technique. Excellent.
Assalamu alaikum. Thanks a lot again for your kind invitation for this prestigious meeting. I'm pleased that I'm after all these great presentations of different techniques. So without due the delay. As we all know, the macular hole presentation, and can we, it's not moving. Next, please. Yeah, so the classification, as we all know it, I would not go through the basics, but what about the etiology? The full thickness macular hole, it is, the etiology is either primary or secondary. Primary is due to the vitreomacular traction, which can cause either full thickness macular hole or lamellar macular hole. The secondary causes, we have trauma, we have high myopia, macular schisis, secondary to macular edema, whether diabetic or cystoid macular edema, uveitic, or branch or central retinal vein occlusion. Retinal detachment with macular hole, whether it is primary from the macular hole or a secondary macular hole, and MACTAL. So these are some of the cases. This one patient, female, 56 years old, she presented to me with a drop of vision to 2200 in the left eye. This is at presentation, a small macular hole. So in such cases, I think the best option is ILM flap, ILM peel, and that's the simplest technique, and actually the best result in visual acuity in such cases. You do not need to do ILM flap in such cases. Just peel the ILM all around. Do not do excessive pinching of the ILM. Whenever you have a flap, just go ahead with it and continue your peel. That's more than enough. And this is the post-op image. We can reach in macular hole to 2020 or 2025 in most of our cases. This is actually a secondary case. She presented to me with, 2 years prior to that with an active choroidal neovascular membrane. For that, she receives multiple anti-VEGF injections. The last was 6 months. This was the OCT at presentation 2 years back. She was treated elsewhere in Oman, so she continued her treatment, but she presented again to me with a full thickness macular hole, and you can see the arborizing pattern on the OCT angiography of actually inactive choroidal neovascular membrane, and you can see the scar of that. And it is a rather larger macular hole. For such case, I think the best way to deal with that is to proceed with an inverted flap. A temporal flap would be my choice, and I hope this is working. Yeah, okay. You can see that, and just a temporal flap. Some petechial hemorrhage that can happen, but always try not to pinch too much on the retina. It is just the ILM itself that we are pinching, and creating a large flap to cover this macular hole. And always in inverted flap, the aim is to make it as flat as possible, not to to be everted back again. Usually, if we do not need a PFCL to flatten this flap, it will persist in place. So under air, and you can make sure that this is well in place. And you can see this post-op images of the same patient. She improved to 20/50, if I remember correctly. This is another patient with a drop of vision in the left eye to 2400. It's not moving. Yeah, so it is rather larger flap, so larger macular hole. So in this case, I used multiple inverted flap, not just one flap, creating the initial pinch. And multiple flaps to cover this hole, to make sure that these flaps would not be re-everted again. and to make sure that this closure would be a permanent closure of the hole. Our aim is always to close the hole from the primary surgery and to prevent this from, to prevent recurrence of this macular hole. I think we can go next. Yeah, so next again, please. So this is the post-op image, multiple flaps closing the hole, and the patient improved visual acuity significantly. This is another patient with a drop of vision in the right eye. Most of them are females, I don't know why. We can see that the large flap, the large macular hole, again, please. Yeah, and same technique, I use multiple inverted flap. We can use, we can work the video. I usually prefer to use dual membrane blue as a stain, just to make sure that it has a better staining of both the ILM and if there is on top an epiretinal membrane, and this would give a better stain of the hole. Usually without air, you can stain. 30 seconds would be more than enough to have a very good stain and to peel the ILM without causing, and only peel the ILM. Again, multiple inverted flaps, and this is the post-op image. This is another patient with counting finger 1 meter. She had multiple surgeries before, and for diabetic, she was traction retinal detachment, and a colleague of mine transferred the patient to me. This was the image at presentation, and this is the OCT. I cannot see that there was a macular hole. Can we work the video, please? So I've seen that there is a still persistent epiretinal membrane, and I did not want to pull too much. So bimanual technique is essential. Although the membranes are not that tough, but it is always better not to create more traction on the retina. And then when I've seen that there is a large macular hole, I've seen that the ILM was already peeled, large ILM peel. I tried to make, to invert a flap from the periphery, but I wasn't able to do so. So I opt to use free ILM flaps to create the flap and to cover this macular hole. So trying to remove as a larger area of the remnants of the ILM that is available. Sorry, can we make it faster? The video? Move it a little bit first. Okay. So, and next, please. Do not need to repeat. So this is the immediate post-op under gas. And this is at, I think, the last presentation of the patient. The vision improved to 20/40. I opt to put silicone oil and then to remove it. Usually, I do not prefer silicone oil for macular holes, but for the detachment and because of the recurrence, I wanted to give this patient a better vision and then remove the silicone oil and to stabilize the retina. Next, please. Next. This is a patient with retinal detachment with large macular hole. In this combination, we need to peel, to make a large peel of the ILM. I used ILM flap to cover the hole. Sometimes we can do it either without the PFCL, or if the retina is extremely mobile, so I would use PFCL to stabilize the retina and to stabilize the flaps. And this is the post-op image. Next, please. Skip, please. Yeah. Okay. This is actually a lamellar macular hole, not a full thickness macular hole. Diabetic patient with large areas of capillary dropout, but the patient started to complain too much about the central vision. So in such case, I removed the epiretinal membrane that was there, then stain again with dual membrane blue. This is actually ILM. This is brilliant blue, I think, not dual membrane blue. It was not available at that time. And then staining and creating multiple ILM flaps to cover the lamellar macular hole in aim to increase the central thickness and preventing, again, extension of the lamellar macular hole to a full thickness macular hole. Can we bring the previous image? This is the post-op. Can you bring the previous photo? Yeah, this is the previous one, the lamellar macular hole, and the next after the surgery. No, next, please. Next, next again, again, again. Yeah, and this is the post-op with multiple inverted flaps. Again, please. And this is the osteoangiography. The capillary dropout areas are the same. It did not change, but the success rate of the vision. I think we can skip this one. Skip it, please, all. This is a patient with laser burn. I was initially thinking that this hole would close, but following up the patient, waiting for a closure of macular hole, I've seen that the hole is increasing. It is not closing. So that's the time that I intervened. And again, only ILM peel would be more than enough. Can we skip, please? And this is the post-op image. The final case, next please, was a boy with a trauma in the left eye with a full thickness macular hole. Sorry, return back again, please.
Ahmed, we're running.
I'm finished already. So this is, it was a full thickness macular hole, but with waiting, the hole was totally closed. So traumatic macular hole, sometimes it can close on its own without any intervention. So not in such cases, not in every case, we need to intervene and do surgery. Thanks a lot. Thank you very much.
Excellent presentation. You've actually covered almost all etiologies of macular holes and how to manage. So a great way to end up today's session on surgical macula.
Can I have one comment? So, I have just a comment and question for all the speakers, including myself. So it was there, do you believe that any macular hole is considered closed and can be closed by stuffing anything? Do you think, just raise the hand, anyone. If anybody thinks that stuffing the hole and plugging the hole helps in closure, okay, it's closed. Does it the technique to do? So, now now comes my second. Now comes my second. Now, do you think for primary macular hole surgery and even for recurrent macular hole surgery, where Levante here, everybody's doing great macular hole surgeries, do you think making a scaffold over the macular hole with the primary macular hole, whether recurrent or secondary, is the technique to do in future for the prosperous of a patient? Just raise the hand. How many think that this is the technique? Who doesn't think that this is the technique? So this is the new concept that we started in 2019 with this technique of grafting the macular hole. And this is the same concept that people are using in temporal flaps and everything. Stuffing it, any macular hole or any macular hole, primary or secondary, I think is not the technique for any visual improvement and not a future technique for anything. That was just my humble.
No,
Yes, Jimpa. You can have mine.
First of all, my congratulations to all the speakers, because the variety of techniques which we've seen just tell you how difficult dealing with these problems is. So anyone doing so is a superhero. My question regards displacement, flap displacement. So when we use amniotic membrane or a graft, the problem is then, will it displace in time? And this is why some people will introduce the flap underneath the macular hole edges. And then generally that's tamponated with long-acting gas. Now, in my hands, personally, I don't like the technique because it's difficult, and I'm always afraid of damaging the RP. So I will use silicone oil. So it's over the hole, and the silicone oil is used to keep the graft in place. I use a direct exchange because, again, air, I'm afraid that may displace during my exchange, but it doesn't really matter. What is your experience with displacement once you remove the silicone oil?
So my technique of putting any grafting, either amniotic membrane graft, I don't stuff it, I just place over it and dip it in, like a U shape. I mean, I don't go underneath the margins of a hole. I just put it, and just with the soft, if I dip it, not plugging, it's like a U-shaped graft that is lying over that. My understanding is that when we have a centripetal movement of the hole, it comes on and it's just this regurge out away the amniotic membrane graft. So how to stabilize it? If you will do under the PFCL or if under the fluid, it's not possible. Our technique is to do under the air. And graft should be little bit wet. When it is very dry, it is very sticky. You cannot hold it over there. So when it is wet and it is under there, it is well placed. And all the patients, in early series, we have the 7 patients where we use the silicone oil. And later on, we were using SF6 gas. Yes, there was incidence of 1 or 2 grafts that has been dislodged. Later on was reoperated. And again, amniotic membrane grafting was done with the silicone oil. No, we have the new ones, yes. I mean, I don't know, because I am following these cases now 6 years. And believe me, I have removed this graft now, because this graft doesn't go anywhere. It stays there. The best thing is we did the microperimetry of this graft. We did the OCTA. There is no growth of any tissue in this graft after 6 years. And in microperimetry, the patient has the same potential of vision through the graft that he gets from the other part of the macular area. Even I removed, in the patient where I put the silicone oil, I removed the silicone oil and I removed this graft. Hole stayed closed. So it is just a matter of giving the scaffold to any hole. If you get a scaffold or any hole, I think it should close and it will close. That's understood. Yes, please.
Yasmin, the technique you showed is extraordinary, and I hope it works. I think I forgot the name of the lady that does it in Spain as well. It's slightly different because she doesn't use the amniotic membrane, she just uses the enriched plasma. But this is revisiting an old concept, because back many years ago, we all did, according to Smitty, we all did the closure of the macular holes by using autologous plasma. With that, we got some incidents of endophthalmitis. I myself remember one day going and seeing the patient, the following day surgery, and we had an endophthalmitis. Have you run across any endophthalmitis due to this? Because there's a lot of manipulation. If not, what precautions do you take to avoid this?
Sincerely, at the beginning, we was afraid that it happened. We don't have any endophthalmitis. I suppose because we centrifugate them twice. We just take the the one that doesn't have anything to transmit, any infection, any cell, any inflammation after the surgery. So I think it's secure.
Congratulations, everybody. Fantastic talks. My question is for Dr. Slawomir. My limited experience with amniotic membrane grafts is very similar to Professor Hussein's. I use a small graft under air, and it usually sticks in place, a couple of cases. But your technique, you put in a large amniotic graft under PFCL. First question is, do you worry that it might trap some PFCL in the hole? Second question is, later on you showed the hole closed nicely, and the amniotic membrane graft started to peel off temporarily. Would you consider removing the graft later on, since the retinal tissue has healed underneath it? Thank you.
Yes, thank you very much for the question. Of course, regarding the PFCL drops in the macula, you are right, you have to be careful. You have to keep the one bubble of PFCL, and this is actually, and this resolves all the problems. But regarding the amniotic membrane, actually, I do not have as much experience to remove. If I would see that this case, that the amniotic membrane it's cause traction, like anterior capsule, I would remove it. But not, but just I want to answer Giampologini for the question of displacing, because I was fighting with displacing for more than 10 years, and with displacement of ILM flaps. The only one good reason it's how to do it, it's to dry the vitreous cavity, and the best way is to do peripheral vitrectomy, because vitreous contains water, so a large, quite extensive peripheral vitrectomy, fill the eye completely with PFCL and disconnect the infusion line and exchange for the air against PFCL, and this is the best way to avoid fluid. And if you do that, you can usually the ILM flaps or whatever you put over the retina. Free graft from retina, the same. It works the same. The fluid can displace whatever graft, amniotic membrane, or flaps. So if we dry the inside of the eye completely, and this is the only reason. No.
Sorry, just one last comment on your technique, Dr. Slawomir, as well. Do you find that patients complain of a relative scotoma when you put a large amniotic membrane, or do they not notice
I didn't check it, unfortunately. You check it. Yes. Yeah.
Even the large graft?
Yeah.
Okay.
In the blue type, it contracts, it wouldn't stay as large as that size. How we have the disease of that.
I think I have to intervene now. This topic is so interesting that we can be discussing it all day, and it will never, it will never end. I have to end the session now, and thank you very much all the speakers for such lovely talks. Grateful to everyone who participated, and I now invite all the speakers to please come on the stage for a photograph. Thank you.